Ajay, are we good to go?
Yeah, we are now live.
Okay. So, Sumit ji?
Okay, thank you, Dr. Prashant. So, very good evening to all the respected doctors. On the behalf of Mankind Pharma, myself, Sumit Nagpal, we welcome all of you for the online webinar on the Trinity of COVID-19. And we welcome our respected speaker, Dr. Raj Shekhar. Today, the topic is the Trinity of COVID-19. And let me share the key highlights of our organization, Mankind Pharma. 1995 is the year when we launched our organization, and this year we have completed 25 years in Indian pharma. And our vision is to become the most admired Indian pharma company. We are always committed to improve quality of life, and three pillars of our success are affordability, reach, and quality. We are having a very strong presence across various therapy areas like anti-infective, GI, cardiovascular, anti-diabetic, and so on. We are having our own R&D center in Manesar, Gurgaon. There 400 scientists are working, and our major focus is on new drug discovery and APIs. Being a responsible pharma company, we are always committed to help first-line healthcare worker and our employees in various ways. And once again, we thank you, all of you, for your continuous support and encouragement for us.
Thank you.
Now, I'll request uh, our medical advisor, Dr. Prashant Agarwal, to introduce our eminent speaker.
Thank you, Sumit ji. And welcome everyone once again to this scientific session where we have a very eminent speaker from the medical fraternity, Dr. Raj Shekhar sir. Dr. Shekhar sir, I mean, everyone knows him. He's practicing as a consultant physician and diabetologist, Heart and Diabetes Therapy Center at Kumbakonam. Academically, he has published many papers in medical journals and written chapters for textbooks of medicines. He has written book on My Mnemonics in Medicine, third edition, section editor for Yearbook of Medicine 2018, 19, and 2020 also. He is editor of ICP monograph of anemia, history taking and general examination in clinic medicine approach to fluid, electrolytes and acid-base disturbances, and clinical appraisal and handling, appraisal of clinical significance of biomarkers. He has delivered many lectures in API and IMAs, got distinction in several subjects during MBBS, revered teacher and award by East Zone API Assam 2017, Best Physician Award 2018 by Gulbarga College, Karnataka. He has delivered many orations and got Best Doctor Award by Tamil Nadu government and Doctor's Day Award from State IMA. He Professional Excellence Award. He received Professional Excellence Award by Rotary International, Mary John Award from USA for Professional Excellence, Faculty for Cardio-Diabetic Courses, past National Governing Body member API, Treasurer of American College of Physicians India Chapter, President Clinical Cardio-Diabetic Society of India, Editor-in-Chief International Journal of Cardio-Diabetology, and he has been faculty for National and International and Master Teacher Award National API on 7 in 2020 Epicon Agra. So I welcome Sir Dr. Raj Shekhar sir to the dais, and sir, you can now the session is yours, sir.
Thank you. Thank you. Good evening, Dr. Prashant, medical advisor, Mankind, and Mr. Sumit, the marketing team head, and all the participants. And I'm very happy. Mankind Pharma is associated with us for a long time, and they are partnering today's meet. And a hearty welcome to all the participants. Thank you. We'll go one by one. And today, COVID-19 pandemic, everybody is afraid to face the situation. We will see one by one. And I will summarize at the end, as usual, by mnemonics of COVID-19. We are almost in the corner which drug to use and which drug not to use. We'll go one by one.
So please put on the full screen mode, sir.
Okay.
Yes, sir.
Okay. Today we'll go the repurposed drugs in COVID-19. Am I audible, Dr. Prashant?
Yes, sir. Yes, sir. You are.
Okay, okay. So what is drug repurposing? It is also known as the drug repositioning. So the drug repurposing, we call it as drug repositioning. These are the two terms. This is nothing but a process of identification of new therapeutic use or users for old, existing, and the present available drugs. This is an effective method, that is a strategy in discovering or developing drug molecules with the new pharmacological or therapeutic indications. This is very, very important, the drug repurposing or drug repositioning. So this is the traditional drug discovery versus drug repurposing. So what is it? Let us see. So in the market, how it is registered and what is the lead compound, how the target based on organism based, then the screening, that is the candidate drug, then the preclinical development first, and then later on they develop clinically, then they register. And then what is the silico approach? Then the serendipitous approach, and then experimental approach. These are the three components of traditional drug discovery versus drug repositioning. So this is the triad. So this is the selection and validation. So on the one end, the clinically approved drug, and the another that is leads on to clinical development. After clinical development, they register, and then it is being marketed. And then what is the on-target and the off-target strategies of drug repositioning? So first, drug, known target, that is known therapeutic indication. What is the known therapeutic indication? And what is the newer therapeutic indication? So newer therapeutic indication is nothing but repositioning. Then on-target, known target, that is known therapeutic indication. And then the new target, that is a new therapeutic conditioning, again, new repositioning, this is off target. The previous one is on target and the next was in off target. That is, for example, minoxidil, that is moxonidil, which is a centrally acting drug. And it is rather used in the uncontrolled systemic hypertension. Another is aspirin, that is off target, minoxidil, that is on target. So what are the drugs with the potential for repurposing against COVID-19? There are so many drugs. The problem is they may have an effect, but the only thing is the side effects and toxic effects. Any drug, when we start, it must have a potency, it must have an efficacy, it should not have adverse effects. What are the adverse effects? One is side effects, another is toxic effects. When we prescribe a drug, suppose within the therapeutic range, if causes effects, it is called side effects, that is unwanted effects. Suppose it exceeds the therapeutic dose, that is called toxic effects. So both come under adverse effects. Another, the most important thing is the QOL, that is quality of life. It should not hamper. It may cure, but patients should not be having symptoms due to the drug itself. So the quality of life is important. So what are the drugs we use for COVID-19? Remdesivir, then favipiravir, then darunavir, ribavirin, lopinavir, ritonavir, Orbitol, azithromycin, nitazoxanide, that is an anti-parasitic, that is elbasivir, tegobiravir, then sofosbuvir, then the bictegravir, IDX194, then ivermectin, that is a new drug now we are going to focus, again, which is an anti-parasitic, Now it is approved for as an antiviral in COVID-19. Then the prulifloxacin, then cephalosporin, then nafamostit, and nelfinavir, and doxycycline, another drug today that is focused on COVID-19. On the other end, that is the drugs acting on the host. On the left, that is drugs acting on the virus, which we have highlighted now. The drugs acting on the host, that is chloroquine, hydroxychloroquine, ARBs, already patients known hypertensive, we put the patient on ARBs, statins, interferon beta, then interferon alpha 2 beta, then tocilizumab, dexamethasone, and then our roxatinib and baricitinib. So these are all the drugs with the potential for repurposing against COVID-19. This is the drug pharmaceutical category, original indication, newer indication. What is the state of development? See, you can see gabapentin, anti-epileptic, that is epilepsy, for example. And then ivermectin, anti-emetic, that is COVID-19. And metformin, anti-diabetic. So these are all for the examples. That is, what are the drugs under development? Now the melatonin. What is the importance? This is a newer drug and this is a newer innovation which is indicated for our COVID-19. Our Mankind Pharma is positioning this drug. Let us see how it is. So it is Aaron Lerner discovered way back in 1958. The melatonin, also known chemically as N-acetyl 5-methoxytryptamine. It is a naturally occurring compound, very important. It's a naturally occurring compound found almost in all living creatures, that is from algae to human beings. But that is from the lower animals to humans at all levels that vary in daily cycles. So it is known as hormone of darkness. Hormone of darkness is melatonin. It is being secreted in darkness in both day active, that is diurnal, and night active, that is nocturnal, that is circadian rhythm, but what we call it as. Many biological effects of melatonin are produced through activation of the so-called melatonin receptor. Receptor is a site at which a drug acts. So this is how the melatonin, that's how inhibition, retinohypothalamic, that's how the inhibition, that is through retinohypothalamic tract. Then it acts on the suprachiasmatic nucleus. That's where finally pineal gland, and down the superior cervical ganglion. You can see the anatomical representation. So these are all the various food sources you can see from banana, apple, and all, even all those things you can see, and all the vegetable sources and also other food sources. So this is the biosynthesis of melatonin. That is, it is being starting from L-tryptophan. That is acted by tryptophan 5-hydroxylase, then 5-hydroxytryptophan, then serotonin, then acetyl serotonin, and melatonin, and in between the enzymes acting as aromatic L-amino and acid decarboxylase, that is being useful to get it converted to serotonin, and then serotonin N-acetyl, that is transferase, that is NAT, acts on serotonin and converts to N-acetyl serotonin. Then final conversion to melatonin, that is our hydroxynidyl O-methyl transferase, that is nothing but HIOMT, HIOMT. So this is the basic biosynthesis of melatonin. So what are the functions of melatonin? That is about 10 aspects. You can see all the 10 aspects. On the next slide, you can see my mnemonics of functions of melatonin. The first and foremost, regulation metabolism, immune defense, regulation of melanogenesis, neurogenesis, bioenergetics regulation, anti-inflammatory, regulation of sleep, circadian rhythm, which you have seen the previous slide, oncostatic properties, antioxidative properties. Just to see, just to remember melatonin, you can remember all the 10 features, all the 10 functions of melatonin, just to see the melatonin functions. So M stands for melanogenesis. And another thing is metabolism regulation. E ensures the circadian rhythm regulation. L limits inflammation, that is anti-inflammatory properties. A, antioxidative properties. So whenever any disease, they will have oxidative stress. So it has got antioxidative properties. And then it regulates bioenergetics. Then oncostatic properties. O, N stands for neurogenesis, I for immune defense, N for napping. Napping is nothing but a sleep, and also it regulates sleep. These are all the 10 aspects of the melatonin functions. So this is the melatonin. What is infection? What is autoimmunity? Starting from bacteria, virus, parasite, that is infection. Autoimmunity, rheumatoid arthritis, multiple sclerosis, type 1 diabetes, then systemic, that is lupus erythematosus, that is nothing but SLE, and then inflammatory bowel disease. This comes under autoimmunity, and the previous one, very simple, bacteria, virus, parasite. Our COVID-19 is a viral infection. So it comes under infections. This is how the melatonin acts on both. So COVID-19, you can see that is virus, that is reduced mortality and delays disease onset in infected animals. So COVID-19. So this is the COVID-19 complications starting from head to full almost. So first and foremost, neurological complication. Even today, there is a recent article and the autopsy, there are a lot of autopsy findings in the brain, that is neurological complications. Then comes under the most foremost, the ground glass opacity, that is MRI, the respiratory distress, ground glass, even X-ray chest, infection, pneumonia, then cardiovascular complications. The patients will have cytokine storm, that is inflammatory markers, then acute liver injury, then pancreatic injury, then patients finally ends with multi-organ dysfunction due to sepsis, that is nothing but septic shock. Then comes the acute kidney injury. These are all the known COVID-19 complications. So the pathogenesis of SARS-CoV-2 and adjuvant actions of melatonin. So these all ARDS, that is induced complications. One is that is the cytokine storm. It gets, once the SARS-CoV-2, that is the virus, gets infecting the lungs, it causes a cytokine storm. Then that results in organ disorders, sepsis, sleeping disorders, then sedation use, vessel permeability, and then cardiomyopathy, pain. There are also, that is myocarditis is also a recognized feature of COVID-19. So finally, they may recover or they may die. So this is the important thing. So reactive oxygen species increase, reactive nitrogen species increase. These are all on the right side, the inflammatory markers, that is IL-1 beta, IL, interleukin. IL denotes interleukin. And then IFN, gamma, IP10, interleukin 17, and interleukin 10. So it causes disturbances in immune response, that is including CD8 plus T cells, and also the WBCs, that is neutrophils and lymphocytes. So that causes immune response. The melatonin will have an effect. So it causes immune response and it stimulates the recovery. And role of the melatonin in cytokine storm. So the progenitor cells. So on the left, there are some inflammatory markers. On the right, there are the inflammatory markers. So the monocyte, the melatonin acts, that is M1 macrophage, and to the melatonin acts to the M2 macrophage. So the pro-inflammatory, that is the markers, the reactive oxygen species, RNS, reactive nitrogen species, nitric oxide, interleukin 1, interleukin 6, interleukin 8, and 12, interleukin 23. They are all the chemokines, that is nothing but that is inflammatory mediators, and lipid oxidation products that causes a massive cytokine release, that is nothing but a cytokine storm. Then anti-inflammatory, that is interleukin 10, then tumor growth factor, that is TGF beta, PDFGP, and EGF. Then they causes the modest cytokine release. This is how the viral load occurring. So the antiviral effect of melatonin, that is the so-called CD147, that is aging, that is melatonin, CD147, that is how the melatonin is getting acted and being used. The inflammatory markers, that is TNF, tumor necrosis factor, MCP, IL-6, INF, that is a gamma, and then that causes tissue injury. But melatonin is being used to inhibit the tissue injury. So the aging, CD147, inflammatory markers, that causes tissue injury. But melatonin inhibits the tissue injury. That is the use of melatonin in combination with other antiviral agents. It may yield more effective outcomes through the so-called CD147 suppressor effect, that is called immune modulatory effect, and reducing the potential negative side effects of antiviral agents. So this is the left side. You can see a beautiful slide, that is artificial engineering, that is intelligence in the drug repurposing. The network medicine and large-scale patient data analysis from the COVID-19 patient registry and the so-called Cleveland Clinic, that is USA, the researchers found the melatonin intake was associated about 50 to 60% of reduced likelihood of positive lab test result for SARS-CoV-2. So the outcomes of COVID-19 are potentially linked to melatonin production. Aging, compromised melatonin production in the elderly may cause difficulties in coping with the stress of SARS-CoV-2 infection, leading to the highest severity and mortality in this age group, that is aging. What are the comorbidities? You all know obesity, hypertension, CV diseases, and diabetes have relatively high severity and mortality for COVID-19 patients. Once even a normal patient, after affecting COVID-19, it may unmask the diabetes. And compromised melatonin production or altered melatonin receptor function are one of the common etiology of the disorders. The gender, the potential association, the mitochondrial function. We all know mitochondria is the powerhouse, that is the storehouse of the store, that is the factory of the cell. Melatonin action and gender difference during SARS-CoV-2 infection have been addressed in many literatures. The children and pregnant women, children have the highest melatonin levels, and this may be related the less severe symptoms and lowest mortality related to the other age groups in COVID-19 patients. Again, the pregnant women have significantly elevated serum melatonin level, which is approximately twice as high as that of control subjects, or even rather higher. So elderly is no doubt a high-risk group because high stress due to social isolation, diminished melatonin levels with aging, and raised the exposure of individuals to light at the evening, reducing melatonin and disrupting the circadian rhythmicity, which is circadian rhythm is being maintained by the melatonin. We all know it is an important factor attributing to the vulnerability of COVID-19 infection in the elderly. The chronotherapy restores the optimal circadian pattern of the sleep-wake cycle in the elderly it involves. So adequate sleep hygiene is vital, timed light exposure, then chronobiotic medication like melatonin. This is why the elderly as a high-risk group. This is the course of 19, the viral replication starting from incubation. We all know about 14 days, that is as low as 2, as low as 12, or even 14 days. Symptomatic, early pulmonary phase, and then late pulmonary phase. So pulmonary phase is divided into early and late, that is viral debris. So immune dysregulation, cytokine storm, T cell dysfunction, mass, and in between there is delayed innate immunity. So herd immunity is very important, innate immunity, and also the population immunity. Once the patients are exposed to the virus, the cells will develop immunity. That is herd immunity, unless they develop. Otherwise, the vaccines also make the patients to develop herd immunity. Then pathophysiology of neural invasion, a decrease in the pineal and systemic melatonin is an important SARS-CoV-2 susceptibility and severity. the loss of phenylphenolphthalein, that is the induction of the alpha-7 nicotinic acetylcholine receptor, that is in pulmonary epithelial cells and immune cells. They are being the powerful regulator of susceptibility and severity, respectively. The stress, including discrimination, stress, and decreased vitamin D also regulates SARS-CoV-2, including the gut dysbiosis, that is permeability, with a resultant decrease in a short-term, that is a short-chain fatty acid, that is next is butyrate, and increase in circulating lipopolysaccharide. The stress and cytokine induction of the kynurenine pathway leads to aryl hydrocarbon receptor activation, increasing platelet activity, that is also very important, coagulation, then thrombin production, that finally lead to thrombin rise, underpinning the COVID-19 fatalities. This is the exact pathophysiology of neural invasion of the virus. Then in neural tissue, the SARS-CoV-2 recent detection of this virus in the CSF, cerebrospinal fluid, and frontal lobe sections from PM examination has confirmed the presence of virus in neural tissue. The therapeutic use of high doses of melatonin may rather favorably modulate the immune response and neuroinflammation caused by SARS-CoV-2 virus. So this is how the potential melatonin targets, how the hyperinflammatory response, and how the inflammatory response. On the one end, the hyperinflammatory response, on the other end, the inflammatory response. That is sepsis, they may recover or they may even die. The most important thing, anything, the cytokine storm will cause, that is in the pulmonary alveoli, apoptosis is nothing but a programmed cell death, then further edema, then immune response. That's why we always measure the WBC count and neutrophils, lymphocytes, then the CD8 T cells. So that is very important. Replication is multiplication. This is a rough. They have nicely put this chart you can go through. So what are the possible mechanisms of CV injury due to COVID-19? So this SARS-CoV-2 virus, you can see, that causes a cytokine storm, then disseminated intravascular coagulation, and then a direct impact on the heart, that is called direct cardiotoxicity, then hypoxemia. All those things will result in hypertension, diabetes, then RSD, that is respiratory system disease, then cardiovascular disease. These are the clinical manifestations. The potential mechanism of melatonin on the endothelial dysfunction. Any disease will have an endothelial dysfunction. This melatonin potential mechanism on endothelial dysfunction, SARS-CoV-2, that is melatonin, how it is acting on angiopoietin, that is 1 to angiotensin receptors 1 to 7, and then angiotensin 1 to 2, and then 1 to 7. So SARS-CoV-2 always attacks the angiotensin converting to enzyme. That is the entry for the SARS-CoV-2 to enter the cells. So the melatonin will prevent the entry into the cells. So that is very important. This is on the left of the coronary endothelial cells, on the right, the muscle of the heart, that the basic cell of the heart is the cardiomyocyte. You can see the melatonin prevents, that is from cytokine C release, then the caspase and apoptosis, that is a programmed cell death. So the melatonin will prevent that. This is the potential mechanism of melatonin on the endothelial dysfunction of the SARS-CoV-2 virus. So the pulmonary fibrosis, that is a major cause in COVID-19. The interstitial pulmonary fibrosis usually comes, that's idiopathic. But here the pulmonary fibrosis is due to COVID-19. But how the melatonin, it protects lung fibrosis, that is by regulating HIPO-YAP pathway. So this is the lung fibrosis, inflammation, and you can see on the left side, and then it causes fibrosis. That is, fibrosis leads further to chronic lung scarring, that is complete non-function, that is loss of function lung scarring, that is results in, that is a respiratory dysfunction, then it persists rather post-discharge. The melatonin prevents the lung fibrosis, how the fibroblast proliferation, then extracellular matrix, that is cesium deposition, then myofibroblast. That's how that results in lung fibrosis. That's how it acts on the YAP1. That is how it prevents the lung fibrosis, that is by the melatonin. So there is also a randomized multicentral clinical trial. They evaluate the efficacy of melatonin in prophylaxis of SARS-CoV-2 infection in high risk, that is ME-COVID trial. This is a structured summary of study protocol, that is the 2 milligrams of melatonin orally before bedtime, 12 weeks, they have evaluated the efficacy. So the therapeutic potential of melatonin, it has got an antioxidant. We have already seen the 10 functions. So the main functions are antioxidant, anti-inflammatory, immunomodulatory, and finally possible antiviral action. So retrospective adjuvant treatment with the melatonin, that is coronavirus disease, 2019 pneumonia. So they require hospitalization. High dose of HTM melatonin may be beneficial in patients treated with COVID-19 pneumonia, shorter time to clinical improvement, less need for mechanical ventilation, short hospital stay, possibly lower mortality. So the high dose melatonin was very well tolerated. High dose melatonin did not cause any significant side effects except for sleepiness, because it is responsible for sleep induction. That was considered favorable by all patients who are with anxiety and symptom-related sleeping problems earlier. Being a commonly available and inexpensive sleep aid supplement almost all over the world globally, melatonin may play a role as an adjuvant therapy in COVID-19. So a patient is admitted to hospital with the symptoms suggestive of COVID-19 infection. Mildly symptomatic patient on floor, melatonin 50 milligram per oral, that is twice daily for 7 days, and hydroxychloroquine 400 milligram twice daily, and day 1 followed by 200 milligram twice daily for 4 days, that is supportive care. The respiratory symptoms on the other end, evidence of RALS, crackles on examination, that is on the lung basis, and oxygen saturation, less than 94% at room air or requiring supplemental oxygen. Always we have to admit the patient in intensive coronary care unit. Then melatonin 200 milligram per oral twice daily for 7 days, hydroxychloroquine 400 milligram twice daily, day 1, followed by 200 milligram twice daily for 4 days. And then supportive intensive care plus escalation of respiratory support is very important. So melatonin is the CV disease and COVID-19, that is SARS-CoV-2, which we have seen, induced endothelial dysfunction and cardiovascular injury are probably initiated by increase in the phosphorylation of levels of, that is JAK2, another cytokine, and STAT3. They result in reactive ROS, that is reactive oxygen species formation. The pathological alterations are speculated to be strikingly reversed by the melatonin. Very well taken point. Then melatonin, even in Ebola, that is, could attenuate the severe viral infections, that's Ebola virus infection specifically. It can rather prevent one of the major complications of Ebola, that is a hemorrhagic shock syndrome, that often contributes to high mortality rate. High safety profile of melatonin given, easy production, inexpensive, and the fact that it can be self-administered made in an attractive potential treatment for Ebola virus pathology. This is how the summary of experimental studies melatonin potential against viral infection, that is so many, that is viral hepatitis, viral myocarditis, respiratory syncytial viral infection. The first is Venzulin equine encephalitis virus infection, that is the foremost one. Then the dose and how they tried. So the covering mouth and nose, very important. Avoid close contact with those who are sick. Avoid traveling to affected cities and areas. Hand washing, melatonin slow release from 3 milligram to maximum 10 milligram. then 60 to 30 minutes before bedtime. Then mask, protective, that is personal PPE, personal protective equipment, melatonin 40 milligram per day, preferably 1 hour before time. That is very important. So it is a potential adjuvant treatment is melatonin in COVID-19. It is effective in critical care patients by reducing vessel permeability. That's very important. Anxiety, sedation use improves sleep quality. Also, it is beneficial for better clinical outcome of COVID-19 patients. There is significant data that show that melatonin limits virus-related disease, so it is rather beneficial in COVID-19 patients. You can see the reference by Zhang et al. So vitamin D, again, the role and melatonin as a synergistic treatment. Vitamin D and melatonin suggest to be a good option therapeutic for overcoming or attenuating the severity of COVID-19 related pulmonary complications. Both vitamin D and melatonin have shared, that is underlying mechanism, common soil, that are able to modulate and control the immune adequately and oxidative response against COVID-19 infection through a synergistic interaction. Again, the RAS, that is renin-angiotensin system, that is exaltation with a consequent inflammatory response as a leading role in the pathophysiology of COVID-19 infection. So it may be downregulated by vitamin D and melatonin in many organs. Melatonin further, it inhibits the COVID-19 induced the cytokine storm, which is the basic pathophysiology of COVID-19 infection. Exogenously administered melatonin, it reverses the aerobic glycolysis by repressing the both HIF1 alpha and also mTOR, thereby designating the PDC activity. So it allows the acetyl coenzyme A synthesis. So it ensures locally produced melatonin production. The functionally, it reinstates the mitochondria generated melatonin in combination with the parenteral melatonin. So dual mechanism of action, the melatonin itself given outside by oral, it itself produces reinstates the mitochondria generating melatonin, and also parenteral melatonin provides a formidable weapon and to reduce the cytokine storm as well as the damaging consequences. Further, finally, it relieves the signs of COVID-19 infection. So the glucose metabolism in activated immune cells, the melatonin inhibition of COVID-19 disease. The melatonin, it rather forces activated immune cells to abandon aerobic glycolysis, that is in favor of mitochondrial oxidative phosphorylation. It may reduce the formation of pro-inflammatory M1, that's macrophages, and convert them to macrophages of the M2 phenotype, which are rather anti-inflammatory. The melatonin could also be given as an adjuvant with other toxic pharmaceutical agents with a high likelihood it would reduce their side effects. So this is how the melatonin, you can see the overactivation, persistent of viral induction, then astrocyte and T lymphocyte activation, that is BBB disruption, the cytokine storm, and then the BBB BBB in disruption, that is the synaptic loss in the neurons and neuronal degeneration. That's how the neurological sequence occurs. Starting from SARS-CoV-2 ACE2 interaction, antioxidant, anti-inflammatory, anti-immune, that is an immunomodulatory effect, the control of systemic antiviral response, and a pro-inflammatory cytokines that results in control of sleep disruption, agitation, and delirium, and also that prevention of so-called brain fog and cognitive decay. That is knowing, understanding things is cognition and results in CNS health. That is on the left side, and the right side we have covered. So this is how the melatonin acts, and starting from SARS-CoV-2 vaccination, chronic neurological sequelae, acute neurological sequelae, comorbidities, and then the SARS-CoV-2 infection, lungs, inflammation, then immunoregulation, oxidative stress, the so-called chronodisruption. And this is how the so-called nutritional and also the multi-organ failure occurs. how the melatonin acts, you can see, on all the other ends. So this is about melatonin. So the so-called ivermectin, we have been thinking about ivermectin. There are a lot of studies for ivermectin. We are also going to show one recent study of ivermectin. It is an anti-parasitic. It is also used for Strongyloides stercoralis and also filariasis. So this is how the course of COVID-19 and general approach, that is incubation, symptomatic, which I have already told, ground glass infiltrates, clinical symptoms, treatment approach, potential therapies. Just you go through ivermectin 12 milligram twice daily. We will see one by one. What is triple therapy, quadruple therapy, we will see soon. The pharmacological therapy of COVID-19 stage, that's work and what has failed. Pre-exposure, post-exposure, incubation. Hydroxy, remdesivir, lopinavir, interferon, tocilizumab, convalescent serum, corticosteroid, ivermectin. Ivermectin, pre-exposure, post-exposure, incubation, yes, benefit. Symptomatic phase, yes, benefit. Pulmonary, inflammatory phase, benefit. Whereas other drugs, on one end, there is some benefit, pre-exposure. On the middle symptomatic phase, there may be failure, no benefit. And finally, that is no benefit or just, it gives even harm, pulmonary, inflammatory phase. But in all the three phases, that is pre-exposure, post-exposure, incubation, symptomatic phase, pulmonary, inflammatory phase, ivermectin is found to show benefits. So ivermectin in India, it is recommended for the treatment of prevention of COVID-19. It is very well used to replace hydroxychloroquine, which is also a drug of choice for malaria, and also even we are prescribing for diabetes. The drug also, the ivermectin for front health line workers in COVID-19 hospitals. The ivermectin, again, a repurposed drug for prophylaxis. Ivermectin, FDA approved and DCGI approved. That's anthelmintic, strong antiviral properties. Due to strong antiviral properties, ivermectin is a therapeutic option in the prevention and treatment of mild, moderate, and severe cases of COVID-19, especially in early viremic phase. It is also used across the severity of COVID-19. It is a potential to convert patient one COVID-19 it to become negative quickly. This is how the representation, the mode of action, that is very important. There is a receptor in the human cells. So that receptor transports the material from outside to inside the nucleus. Then the coronavirus binds to the importin and enters into nucleus and reduces the antiviral activity and leads to increased infection. That is ivermectin, that is prevents, that is transport material, that is to the coronavirus binds. That's where it acts, you can see. That is transportation of material from outside to inside cell and prevents that the coronavirus binds to importin, enters into the nucleus. So it maintains the antiviral activity and leads to reduced infection. That's how on the right side, there is a diagrammatic representation. So the most important feature, that is ivermectin, that is it concentrates in the pulmonary tissues around 3 times the plasma concentration. So better results in COVID-19. At 24 hours, 93% reduction in viral RNA. We all know the COVID-19 is nothing but a RNA virus. And in 48 hours, the viral loads were decreased rather 5,000 folds. So 24 hours, 93% reduction, and 48 hours, there is a decrease of 5,000 volts. Then what is ICON study? That is ivermectin in COVID-19. Number of patients, 280 severe COVID-19 patients, and COVID showed lower mortality rate than usual care. What are the parameters on usual care? 80.6% mortality rate. Patients on ivermectin, rather mortality rate reduced to 38.8%. So this is an observational registry. In USA, patients on ivermectin on conventional treatment, definitely ivermectin mortality rate is only 7.7% when compared to 18.6% on conventional treatment of the patients on regular drugs. The hospital stage also reduced to 11 days, whereas the other drug 16 days. The ICU stay ivermectin 6 days, whereas the other drugs 8 days. So the South America, that is Dominican Republic study, they have also done about 1,300 patients, dose about 12 milligram to 24 milligram, that is 200 to 400 microgram per kg body weight. 99% of patients were cured. The duration of infection went down to 10 days rather. So ivermectin improves the prognosis of patients. This is the parameter, ivermectin standard care. That is number of patients percentage starting from pneumonia and CVD, oxygen inhalation, respiratory distress you can see, needed antibiotic treatment, how very much reduced, intensive care management almost as low as 0.9%, and patients COVID negative even in 4 days. Shorter hospital stay, 9 days. Mortality rate, 0.9%. Very important on the standard care on the right side. Very important. It is mortality rate is 6.8 days. The duration is also rather high, 15 days. So the comparative study between ivermectin plus doxy and hydroxychloroquine and that is azithromycin. The parameters, that is ivermectin, doxy, azithromycin, hydroxychloroquine. Therapy duration 10 days, this is 14 days, azithromycin, hydroxychloroquine. Recovery rate, ivermectin, doxycycline, 100%, it is 96.36%, that is azithromycin, hydroxychloroquine, about 4% less. And negative PCR in rather less than 9 days, it is about more than 9 days, azithromycin, hydroxychloroquine, marginal difference. Adverse events, that is 31.61% in ivermectin, doxycycline, but azithromycin, hydroxychloroquine, it is rather 46.43%. The symptomatic recovery, ivermectin, doxy 55.10, it is only 23.8%. So better symptomatically, shortened recovery duration, reduced side effects, superior compliance due to less duration and therapy and less side effects. So this is the triple and quadruple therapy with ivermectin effective in treating COVID-19. That is from the Australia, 2 treatment regimens have been proposed in COVID-19. That is what is triple therapy, a combination of ivermectin and the basic mineral zinc, another antibiotic, that is doxycycline. And quadruple therapy, apart from ivermectin, zinc and toxin, they added vitamin D, that is quadruple therapy. So the role of ivermectin in prevention of COVID-19 infection along, that is healthcare workers in India, it is a matched case control study. They conducted All India Institute of Medical Science, that is Bhubaneswar, that is yet to be published. And ivermectin prophylaxis was taken by about 77 controls and 38 cases. 2-dose ivermectin prophylaxis, 300 microgram per kg with a gap of 72 hours, associated with rather 73% reduction of a COVID-19 infection among healthcare workers for the following 1 month. This is the UP government. That is the dosage and duration regarding the prophylaxis and treatment of COVID-19. What they recommend, that is 200 microgram per kg for prophylaxis person who comes in close contact with COVID-19 front-line health workers. And then treatment COVID-19 patients asymptomatic and mild. The dose 200 microgram per kg body weight, day 1 and day 7, 2 hour post dinner. Day 1, day 7, day 30, followed by once in every month. For 3 days, 2 hour post dinner. This is the UP government recommendations. Then West Bengal, that is prophylaxis and treatment. COVID-19, ivermectin, 12 milligram once daily, day 1, day 7, and followed by 12 milligram once every 30 days. For treatment of mild to moderate, ivermectin, 12 milligram once daily for 5 days, plus doxycycline, 100 milligram twice a day for 7 days. This is for mild to moderate COVID-19, that is they added doxycycline in addition. So the safety, it is relatively demonstrated to be generally well tolerated, side effects mild, nausea, vomiting. Pregnancy category C, we have to be little careful. Nursing mothers excreted human milk in very low concentration to be taken on doctor's prescription and advice. Pediatric safe, over 15 kg body weight, below 15 kg, and weight safety has not been still established. Geriatrics, no evidence of adverse reaction in elderly population seen in comparison to younger age group. Diabetes and cardiac patients, no evidence of adverse reaction. So this is the guidelines. The melatonin is recommended from day one, and East Virginia Medical School prophylaxis and mild symptoms. You can start melatonin, that is 0.3 milligram, and increase as tolerated 2 milligram at night. And for mild, you can patient up to 10 milligram. So, and HS, that is at night. And this is the hospital treatment, MAT hospital treatment protocol, that is methylprednisolone IV, and A, ascorbic acid, T, thiamine, vitamin B1, and H, low molecular weight heparin, that is statin, zinc, vitamin D, famotidine, melatonin. So this is FLCC frontline COVID-19. So MAT, M for methylprednisolone, A for ascorbic acid, T for thiamine, and H for heparin, plus the basic statin, zinc, vitamin D, famotidine, melatonin, magnesium. So prophylaxis protocol and plus early outpatient treatment protocol, ivermectin prophylaxis 150 to 200 microgram per kg once weekly. Post-COVID, 200 microgram per kg one dose, repeat it in 72 hours. Vitamin D3, 1000 to 3000 international units per day. Vitamin C, 1000 milligram twice daily, and quercetin, 1250 milligram per day. And melatonin, 6 milligram before bedtime and causes drowsiness. Zinc, 100 milligram, aspirin, 80 to 100 milligram per day. Early outcome protocol, ivermectin, 200 microgram per kg, vitamin D3, 4000 international units, vitamin C, 2002 to 3 times daily, and quercetin, 250 milligram, again vitamin C derivative, melatonin, 10 milligram before bedtime, zinc, 200 milligram per day, aspirin, 325, unless contraindicated, aspirin is also mandatory. This is the prophylaxis and early outpatient treatment protocol for COVID-19. Then post-ICU management, the low molecular heparin, that is enoxaparin, 40 to 60 milligrams subcutaneously, corticosteroids, methylprednisolone over, oral methylprednisolone 40 milligram per day, then wean slowly, that is titrated following CRP, vitamin C 500 milligram per oral, twice melatonin 3 to 6, then Vazipa, icosapentael ether, and Lovaza, all these things, DHA, that is dihydro, that is all, that is omega-3 fatty acids and all group, 4 grams per day, that is important for resolution of inflammation. So all those things, that is 4, A, B, C, D, E, that's 5, that is post-ICU management. I will summarize in my mnemonics. You can see melatonin 3 milligram to 10 milligram, 60 to 30 minutes before time. This is the therapeutic algorithm for use of melatonin in patients with melatonin. So you can see my mnemonics, ivermectin. I stands for ivermectin, reduces the number of cell-associated viral DNA by about 99.8% in 24 hours. This was a vitro study. Now in vivo also, it was proved. Vivo testing is also needed to solve how well ivermectin works against COVID-19. Yes, it is proved. V stands for virus, that is SARS-CoV-2 virus, causes sickness by infecting our cells. Secondly, it has to go into a bubble in the middle of the cell, the so-called nucleus, where the virus makes heaps of copies of itself so it can spread around our body. A protein called the so-called cargo transporter, and the virus needs to work with this to be able to get into the nucleus. Ivermectin rather blocks this cargo transporter, so virus can't get into the nucleus, and thus it can't make copies of itself, stopping virus numbers increase and infection getting worse further. The E elimination half-life 18 hours and renal excretion is less than 1%. Then M metabolism, liver, cytokine pathway, that is cytokine enzyme, CYP 450, mainly excretion in the feces. C stands for cell tissues of lung. Ivermectin is found to selectively, you have seen in other slide, concentrate around 3 times the plasma concentration, so rather better results in COVID-19. And T stands for treatment, single able to effect, you can see 5,000-fold reduction in another cell output in virus at 48 hours in cell culture. Intestinal worms also it is used, Strongyloides stercoralis and Onchocerca volvulus, and even lice, mites. And niche combination of ivermectin essential, that is the ideal combination, triple therapy, which you have seen and highlighted in other slides, ivermectin, zinc, and doxycycline. Quadruple therapy, ivermectin, zinc, doxycycline, and vitamin D. We will see what is COVID-19. And ivermectin in COVID-19 in the dose of 12 milligram BD alone. This is the very recent article. Ivermectin in the dose of 12 milligram twice BD alone or in combination with other therapy for 5 to 7 days may be considered as a safe therapeutic option for mild to moderate or severe cases of infection. It is cost effective, especially when the other drugs are very costly and not easily available. You can see the reference white paper on ivermectin as a potential therapy of COVID-19. It is published in Indian Journal of Tuberculosis. This is a very recent article, July 2020, that is nothing but the great pulmonologist, Dr. Agam Vora from Mumbai, my dear friend, and V.K. Arora and Bihara. And hearty congratulations to Dr. Agam Vora and his friends. This is an Academy of Advanced Medical Education. This is a white paper on ivermectin as a potential therapy of COVID-19. So how do you spread? Just remember my mnemonic 7 Ds. D for do stay home. D, do wash your hands frequently. D, do not touch your face and unwashed hands. D, disinfect regularly the surface and items you might touch. D, distance yourself from those who are coughing or sneezing. D, do so into your elbow if you cough or sneeze. D for dispose of tissues after one use. So coronavirus, you can see my mnemonic. C stands for coronavirus, that's a Wuhan virus. O order, that is nidovirus. R reservoir, primary bat. Overt manifestations, they may mimic like that of mild flu symptoms, later progress towards ARDS, that is septic shock. N, novel virus, spreads very rapidly and posing a high risk due to increased genetic diversity, recombination of their genomes, increased human-animal interface activities. No antiviral or vaccines are now available, but now many drugs are available under treatment and prevention of this deadly virus. The adaptation of coronavirus occurs frequently, rapidly, and because of the presence of the so-called error cone, that is RNA-dependent RNA polymerase. So this enzyme is responsible for the increased frequency of mutations and recombination among the coronaviruses. What are the clinical features? A, B, C, D, my mnemonic. A, anorexia and 40%, anosmia, that is the loss of smell, sudden recent onset, that is loss of taste sensation, anosmia, nasal block, and sinusitis to be always excluded. Then B, body temperature, fever in 99%, body ache, myalgia in 35%, sore throat and headache in 30%, C, cough, dry cough, 59%, dyspnea, difficulty in breathing, 31%. E for expectoration, sputum protection in 27%. Pneumonia seems to be a common presentation of COVID-19. And the features of fever, cough, dyspnea, and bilateral infiltrates, that is ground glass opacities on chest imaging, but no apt differentiation of COVID-19 and from other viral respiratory infections rather. Then COVID-19, what are the diagnostic tests? Just remember by mnemonics A, B, C, D, E. A, antibody detection, immunoglobulin M, 5 to 7 days, and IgG immunoglobulin G 10 to 14 days. We all know immunoglobulin GAMDE, that is GAMDE. So here M and G are very important. Application of test, that is RT polymerase chain reaction, is the gold standard for diagnosis. B, blood test normal to lower total WBC count and lymphopenia, lymphocytes less than 20% on differential count, and lymphopenia and eosinopenia, that is less than 150. And clinical features of COVID-19, just remember A, B, C, D. C, coronavirus, that is positive pregnant lady, child should be tested immediately after birth. if child is negative. Then child should be separated from the mother as long as mother is infectious. Chest X-ray is a standard of care, but insensitive for diagnosis for early stage. Good in later part of the disease rather. CT chest is a surrogate diagnostic test, especially useful when there is a mismatch between clinical and epidemiological suspicion and PCR test, polymerase chain reaction test. CT chest, the patients in CT chest reverse halo sign is characteristic by a central ground glass opacity, that is GGO, surrounded by a more or less a complete ring of consolidation on a high resolution CT, that is HRCT. It is also described as atoll sign because of the resemblance to a coral atoll. The CT finding against COVID-19, pleural effusion, lymphadenopathy, tree in bud opacity. The D stands for diagnose. If clinical suspicion is high and PCR negative, then repeat the test after 48 to 72 hours. Diagnostic modality, that is apart from CT chest, that is focus, that is point of care of ultrasound is focus, is good for daily follow if X-ray is not feasible. Then clinical features, elevated liver enzyme E, elevated lactate dehydrogenase, elevated inflammatory markers, C-reactive protein, ferritin, CRP and serum ferritin are surrogative markers for interleukin 6 for cytokine storm syndrome. Elevated D dimer more than 1 microgram ml. Elevated prothrombin time, elevated troponin, elevated creatine phosphokinase, elevated renal biomarkers indicative of acute kidney injury. Then COVID-19 drugs, that's what we have highlighted, our mnemonics. C stands for chloroquine, hydroxychloroquine, convalescent plasma, corticosteroid, again, is a questionable value, especially convalescent plasma. Then O stands for oseltamivir, not effective, but patients presenting symptoms may be influenza. Again, it is so effective in influenza. When we are unable to differentiate, for benefit of doubt, you can give oseltamivir. Then vaccines under there, they are about to use. Then interleukin 6 inhibitor, nothing but tocilizumab. Then inhibitor of viral RNA dependent RNA polymerase, that is favipiravir, then Avigan T705. And I stands for our today's talk, I for ivermectin. And D drugs, ACE inhibitors, ARB is questionable. And now our today's talk, doxy, and another important drug is melatonin. We all know the role of melatonin. D drug combination, lopinavir, ritonavir in vitro. Tried in combination with the interferon alpha, ribavirin. Then R stands for remdesivir, U, that is umifenavir, the brand name is Orbital. It is not FDA approved. Then globulin G, immunoglobulin IV. Then secondary infection, if patients have got secondary infection, you can initiate and put them on antibiotics. So thank you very much for so we have put forth the importance of COVID-19, how it can be managed very simply and with better drugs. Now the melatonin is responsible for sleep induction, and it has got a 10 metabolism, that is the 10 functions which you have highlighted. And another thing is ivermectin, though it was anti-parasitic, it is also tried. We have highlighted the triple therapy, quadruple therapy. Triple therapy, that is melatonin, ivermectin, and zinc. Quadruple therapy, apart from these three drugs, ivermectin, doxycycline, and zinc, they added vitamin D. So very, very important, all these things. So I'm very much thankful to our Mankind Pharma for this, their innovation of melatonin and the utility of ivermectin. They are not a very costly drug. They are rather cheaper drugs to get utilized in COVID-19. Let us wait and combat this COVID-19 pandemic situation by these two wonderful drugs. Thank you all.
Thank you, sir. Thank you so much for this wonderful session, sir.
Okay.
And the way, sir, you explained each and every detail, I really feel, I mean, each and every doubt, I mean, whatever has been there to our audience definitely have been removed now. And so, sir, actually, there are a couple of questions.
Okay.
So Sir,
Yes,
one thing they want to have comment on vaccines, sir, because
Right.
definitely that is a hot topic nowadays. So, what is your comment, sir, on vaccines? I mean, that is the simply the one question. Sir, that is, sir, can you hear me?
Yeah, please.
Okay. Sir, there is one question. They want to comment on COVID-19 vaccines. So, how it will work, or how, I mean, the practicality of that vaccine, sir.
Yeah, practically so far 2 vaccines they have said that they have nodded. There are so many vaccines, about 6. So we have to wait and see how the patients will respond, because, for example, there are so many studies in so many trials. One study may not hold good for other study. So they are they are selecting the places where they are going to try the vaccines. We have to wait and watch how the herd immunity is going to get developed due to this vaccine. So herd immunity is very important. One, if 70% is 70% of persons get infected, then the herd immunity develops. That is a population community immunity. Suppose the vaccines are injected, then the patients will develop herd immunity. That's people, public will develop. So let us wait and watch how the patients will respond, how it is going to be successful. Because the scientists have taken their life and they have done very good research, and let us have a positive impact on the vaccines. We cannot comment on that unless the results are coming out. Let us wait and watch. Let us not go into the false rumors. Very, very important.
Thank you, sir. Sir, the next and last question is actually they want to understand about the asymptomatic patients. So, how should manage the asymptomatic patient?
Asymptomatic patients, suppose they have got a contact with a person. Suppose already they have had a very close contact. Suppose they suspect themselves. Always asymptomatic patients always do a basic immunoglobulin test they can do, and basic this RT-PCR test they can do, and they can quarantine themselves at least for a week or two. That is 10 days to 14 days. Very important. Asymptomatic patients. Asymptomatic patients may not develop in future also. Even symptomatic patients may even be negative. So we can't go. That's a problem is COVID-19. We are all standing. We can't go forward. We can't go left. We can't go right. We can't go backwards. That is the problem. So we have to be careful, and we have to adapt the prophylactic measures. That is the preventive measures. Prevention is better than cure is always an ideal. That is a proverb. So at least we have to prevent ourselves. And if the patients are suspected, better to have an early intervention is very, very important. Let us please advise your patients, let them not wait. They should not go and get admitted in ICU, and then the problem comes, because even they go into ECMO, extracorporeal oxygenation. So they should not go to that extent. Once they are symptomatic, asymptomatic, no problem. Once they become symptomatic, better to get admitted. Asymptomatic, when they have a suspicion of a close contact and all, better they quarantine themselves. At least they should not infect others. That is mandate. Thank you very much.
Thank you, sir. Thank you, sir. That was the last question. And again, sir, it was really a wonderful session, sir, you had. So, on behalf of whole Mankind Pharma family, sir, we would like to thank you. And definitely, sir, in future also, we will continue these kind of educational activities for our audience with you, sir.
Okay.
Thank you, sir. Thank you.
Thank you so much, sir. Thank you.
Okay. Your people are also with me. Your manager and representative are with me.
Okay.
Thank you. They are coordinating very well. Thank you.
Sure. Thank you, sir.
So he is.
Yes, sir. Thank you, sir.
Okay.
He is from Pondicherry. Okay.
Yes, sir.
Thank
you, sir.
I will leave.
Okay.